their applications. Not much detailing about the procedure. Clear? So, which one should I tell first? Tell me. Huh? RFLP. Can we start with this? This or this? Huh? Do we have DNA? We have two types of DNA, genomic and mitochondrial. We have, if every nucleated cell must have at least one molecule of genomic DNA in our body and a number of double-stranded circular DNA which will match with the number of mitochondrial units. Clear? That is the total number of DNA molecules present in one cell. A cell which is devoid of mitochondria and nucleus will not have any DNA molecule. For example, mature. Clear? So, the genomic DNA, all of us, we all are human beings, but do we look alike? No. But we all can digest, eat and metabolize in the same manner. The same paracetamol molecule, the same norfloxacin will act on our body in same way. Correct? So, our metabolic enzymes are all uniform. What is different? Our look, our get up, our belly size, correct? Our voice, hair, color of iris, everything, by which we can recognize, we can distinguish between two individuals within the same species. Within the same species. Clear? Now, this differentiation has something to do with that of the DNA molecule. Do you agree? So, suppose, me and she, both are human beings. Nil jama dara. She also human being. Any doubt? No doubt. Are we similar? She is thin, I am fat. She is healthy. Correct? She has small hair, thin hair, she has thick hair. Everything is different. But if a particular type of food is given, we all can digest the same way. Clear? Our LFT liver function test, our thyroid function test should be normal. When we write the normal reference level for thyroid, TSH, thyroid hormones or TSH hormone, we do not mention the name that for Dr. Sandeep Ghosh, TSH normal value will be such and such. Do we do like that? No. We just write a single range for all whole species. Clear? So, what makes us different? We three? Which part of DNA? Which part of DNA? The coding part does not part of the DNA is responsible for these differences, which is also called junk DNA. Which part of DNA is responsible for this variation? Non-coding region of the DNA, and which is also called junk DNA, which is also called satellite DNA. So, these three words are identical. Right? Now, we are human being because of (99.9% of the genome being similar. We do not have tail, we do not have paw, we do not have claw. Correct? Huh? We are human being. We are not like monkey, we are not like dog, we are not like horse, not like fish. So this 99.9% of genome is responsible for making us human. But 0.1% junk DNA, satellite DNA or non-coding DNA is responsible for this variation. Clear? So how to identify between two individuals? It was first proposed by some officials of Calcutta Police rather, in British era, that fingerprinting will differentiate two individuals. Fingerprint. No two individuals will have similar or identical fingerprint, even though they are twins. This was discovered by some person from Calcutta Police in the British era. Yeah. Later on, it was taken up by many of the Scotland Yard and other police departments of the yard. So DNA fingerprinting, we know the same kind of printing pattern can be found in our DNA. In which part of DNA? That 0.1%, 99.9% is same. It codes for what? The 99.9% DNA codes for what? The enzymes of glycolysis, amylase, lipase, how the pancreas will look like, how the brain sulcus will look like. Correct? Eyes should be in front of the skull, not back. All these are designated by 99.9%. So that 99.9% will remain same. We cannot differentiate between two individuals using that 99.9% unless they have a chromosomal aberration like trisomy, nullisomy, etc., etc. Correct? So we have to rely on that 0.1%. That portion is called junk DNA or non-coding DNA. Now, what is this important for? The junk DNA or non-coding DNA is actually more important than the rest of the 99.9% DNA. Why? Because it dictates, it shows a trail. Trail means traceability. It shows a trail of our genetics from the first ape, how we developed, our story of evolution, that 0.1%. So before 1990, all works were done on 99.9% DNA. After 1990, they started working on this 0.1% DNA. Correct? It was so important. Now, RFLP full form RFLP. Now, how do you pronounce it? Pronounce it like this. Riff lip. RFLP, we pronounce it riff lip. If you say RFLP, you are a novice in science. If you say riff lip, you are a graduate in science. Huh? Fine. So this is how you pronounce it. Next is VNTR, as is said, variable number tandem repeat. So what is tandem repeat? Say for example, suppose this is around How many bases are there? কটা আছে? হ্যাঁ 16টা 3 4 5 6 7 8 9 10 11 12 13 14 বাহ very good. Now in that junk DNA, suppose me having this 16 nucleotide sequence 50 times, he is having 48 times, she is having 55 times, someone is having 31 times, someone is having 35 times. Correct? So if we can count how many times of these are present in my DNA, so that becomes an unique feature for my DNA. Like fingerprinting. So fingerprinting word is actually a large area covering word. It's a process by which we differentiate between two individuals using their DNA. That's all. Now, which process we use for identification of the individual DNA? That varies. Okay? The most crude one is RFLP. Of what? DNA fingerprinting. সবচেয়ে ক্রুড প্রসেস হচ্ছে RFLP, reflip. Next modified is VNTR. Next modified is STR. Next modified is SNP. Good. So DNA fingerprinting, you become A, then under A this will become 1, 2, 3. Correct? Most crude one is reflip. Next modified VNTR, next STR. So now my question is, what is the difference between VNTR and STR? I said, if you can recall, while writing this, I stopped for counting for some reason. Why? If this base sequence is around 10 to 16 or more, we call it that's all. If it is shorter, is it? All you need to remember always at this level is a basic difference between the terminologies. You should be well acquainted with the terminologies. Rest all how you do it, how to do, everything is given in YouTube. In the evening, instead of going through unaccounted, unuseful reels, if you go through those videos, it will be very helpful. So STR means when the base sequence range is smaller, 6 to 8. Okay. Now why I say it is more modified? Because we are increasing the power of microscope. RFLP means the whole DNA molecule suppose this is a chromosome. What is DNA, what is chromosome will come later. But this is chromosome, you know what is called chromosome. This is a whole chromosome, not the half, chromatin. Consider it as whole chromosome. You see the other half, it will give the same unless there is allelic polymorphism. So that's why I don't want to make it complicated. So I drew a single strand showing it as a full chromosome instead of calling it as chromatid. Am I clear what I am drawing? I could have called it chromatid, but I am calling it as chromosome in order to simplify the matter so that you don't get confused. Okay? Don't worry, I will confuse you after some time. For the time being, let us consider this as a whole chromosome, and suppose one restriction enzyme we have used on this chromosome. So this will show like this, correct? Now this is my chromosome, and this is Riju-Mondol's chromosome. We digested the same chromosome with same X restriction endonuclease. This kind of pattern. Are they similar? No. Right? So, how many fragments we will get in this? 1, 2, 3, 4, 5, 6, 7. Right? But, okay, fine. 8 for better understanding. Make it 8. Both the chromosomes are cleaved 7 times by the enzyme. But are the lengths same? Are different? That's why it is called polymorphism. Length polymorphism. So just by cleaving and separating the DNA fragments, we can make a pattern. We can make a pattern. Now, problem is, when it was first discovered, it was good, it was well accepted. The problem arose later when they found that DNA electrophoresis is a very cumbersome job, taking the whole DNA. Because this is an example where I have shown only 7 sites. In our DNA, that particular X might have 232 segments, 1,500, 606 segments, or 3,000 segments, or 7,000 segments. How to determine how many segments will be there? Because these restriction endonucleases have got some restriction site. Depending on the basis of the length of the restriction site, we can do the math. Probability of having maximum number of fragments. So that will come in thousands. So DNA electrophoresis usually used to be done in a 1 meter long tube. If we do it in a small gel electrophoresis slab, we can never distinguish between 2 fragments because they will differ by 1 or 2 bases. That will not be separated. So we need to increase the gel length. How long? 1 meter. Very long gel. Right? This is called capillary electrophoresis. So DNA molecules, after digestion with restriction nuclease, they are separated by capillary electrophoresis to find out the different fragments. The problem is there are too many fragments. It will take long time, months to identify. Right? Rather, if we take a fragment of DNA, correct, and find out how many of these are present here. Suppose VNTR, this particular 16 base segment, long segment, are present 4 times. Where? in my chromosome. Whereas a similar fragment from rhesus will have 3. So now we can differentiate between two DNA. One DNA is having 3 VNTR segments, another is having 4. If it is STR, we are again increasing the power of microscope, making it much shorter. So chances of finding STR will increase. Suppose there are 4 VNTRs like this with the same span. What is the problem now? We are not measuring the length anymore. We are looking for particular sequence. So length we cannot calculate. We can find out the difference in number of VNTR, tandem repeats. The number of tandem repeats same. So Rijumondol and myself will be same. So when we cannot see anything separate, what we do? We increase the power of microscope and then it separates. It's called visual acuity. The minimum distance can be seen by eyes. So increase the magnification. Now instead of using 16 bases, we are using 16 bases. So there is less possibility that we will have again same number of fragments. Being STR, this might have 7 and this will have 5 differentiated. Now suppose, very bad luck for you. Even the number of STRs are also same. What do you do? Increase the power of magnification. Go for there we will find difference. Must be. Otherwise, someone has changed the sample. Why I am saying must be? There is nothing called must be in this molecular biology field, because there is something called statistical probability. If you go for statistical probability, in 6 crore nucleotide, there is a possibility that 2 nucleic acid will have same to same junk DNA. But the number is very big, which is almost double the population of whole world's population. So for the time being, we can conclude that that is not possible. That's why whenever any legal steps against a criminal on the basis of DNA identification has done, it is done with some sort of small question mark. It might not be similar. So they must rely on other associated evidences. In sight of other associated evidences plus DNA fingerprinting, we can conclude that these two men are identical. The killer in Rijumondol's house last night and myself are same. I killed his father, made her rich, and came back and caught by police. So now you test my DNA with the 1 drop of killer's blood in her house. You find my DNA and that DNA same. You prosecute me, I'll be hanged. Happy is you? Fine. So this is how the things go on. Now, after everything, I told almost everything except this one. What is that? The satellite is a chromosome. These are called telomeres, end of the DNA. Correct? So, satellite DNA or junk DNA are usually found in this region or in this region, near centromere or near telomere. Tell me why. Why not these junk DNA are found in this area? Tell me why. Because these regions mostly remain bound with centromere area with other proteins. They are hardly unfold, open, and these regions might get lost, not this side, sorry, one side only, might get lost during replication. So, if any important genes are kept at the border or at the region where it separates during mitosis, then genes will be lost. There is a possibility that genes will be lost. That is why nature or Almighty kept those junk DNA either near centromere or near telomeres. Am I clear? So, satellite DNA or junk DNA or non-coding DNA are same. They are the regions of DNA which comprises 0.1% of the total genomic DNA and which codes for no protein at all, no protein. But they are good, important for two reasons. Number one, for identification of two individuals within the same species. Number two, for trailing the evolution. Correct? Any question so far? Any question so far? No question. Fine. Next question. Now we come to the popular topic, DNA fingerprinting, finding the biological samples from the crime scene. Grievous rape case has occurred in a locality, and as a forensic expert you receive some biological sample. It might be hair follicle of the killer or the suspect, it might be semen, it might be blood, it might be epithelial cell, whatever it may be. Fine. Now we have collected. Now you want to take the samples from the suspects caught by the police. From that area, vicinity, police has caught 10 people or 2-3 people who are most probably suspected for that particular crime. How to differentiate? How to collect the tissue? If you collect the tissue from the DNA, from the tissue which is easily available, then your work will be less. You can collect tissue from the bone also. You know, cutting the man's hand and reaching out to bones and taking a piece of bone and then digesting it with strong acid, then throwing away the collagen part, elastin part, and then separating the cells, then separating the osteoclasts, then separating the DNA. Or you can take a blood sample, or you can take a scrap of the squamous cell, that also will do. Right? So it depends on the source of the cell. Yeah. Veterinary tests. If you can remember, one well-known politician in India once faced this problem. At his old age, one fellow came and claimed that he is his biological father. Obviously, he denied, because he has got a family with children, grandchildren, grandchildren. Okay, well-known politician. I don't want to take the name. You will find it out. Anyway, so then the case ran for quite a few years, and then they went for DNA testing. They found the old man is lying. Old man is lying. The young fellow is actually the biological son of the renowned politician, and he had to give his right. Huh? Just go through our restriction fragment length polymorphism or reflip. How do we do it? We just take fragments of DNA and then digest it with restriction endonuclease, and then find out what are number of fragments we are getting. We separate it by southern blot. We identify them by their chain length, molecular density. So that's why in some books you might find this word, the molecular density. Molecular density of the DNA molecules means if the size is larger, density will be high. Size is small, density will be less, lighter. Now, if the fragment pattern is similar, here to the tandem repeats. You have any question about what called tandem? Tandem means repetition of same thing. Repetition of same sequence called tandem repeats. Repeats means repetition. Tandem means a stretch of sequence which is being repeated several times. Tandem repeat. Okay. What is the opposite of tandem repeat? Arbitrary repeats. Simple. Now is it clear? Arbitrary. Anything. Clear? So just get to know about the terminologies. That's all. So when I say DNA fingerprinting, short question, how should we approach the question? Ideally, you must mention all the processes, if not mentioned otherwise. So DNA fingerprinting is a process method by which we distinguish two DNA molecules. That's all. Methods are different. The same thing can be used for identification of disease. Why only for criminals or false paternity test? We can identify disease. Say for example, SNP is best method for identifying sickle cell anemia or some types of cancers. Identification of types of cancer is very, very critical before writing the regime of oncomedicine. You must find out which gene is affected. Accordingly, you must prescribe the medicine. Correct? classification of cancer is, that's why it's very, very important for treatment. See, this diagram will show whatever I have drawn. Go through it. You have any question, you ask me now. Anyone who is moderately fluent with English, after listening to this class carefully, they can remember forever. You need not to study anymore. But those who are weak in language, English language particularly, they have to study books. You know? Okay. These are few important information. Sometimes they ask in MCQs. Which one? This first line. How many chromosomes we have? 46. Which chromosomes are more prone to find out these VNTRs? Scientists have worked on it, and they told 1, 2, 4, 5, 10, 17. If we look for SAT chromosome, if we look for SAT DNA in these chromosomes, then our results will be faster. We need not to go for all 46 chromosomes. Clear? So remember these chromosome numbers, because this might be asked in some MCQs. 1, 2, 4. However, it is possible for two individuals to have the same profile at 1 or 2 loci. মানে এই যে 1, 2, 4, 5, 10, 17 এই ছখানা ক্রোমোজোমে যখন আমি VNTR STR করলাম, দেখলাম সমান, মুশকিল। তখন আমাকে অন্য ক্রোমোজোমগুলো দেখতে হবে। They might be similar in these 6. Other chromosomes we have to search for. Correct? তার মানে এখানে কি দেখালো? 4, 5, 6. বড় কেন এটা? Tell me why. খুব সিম্পল এর পিছনের লজিকটা। আমি আগে বললাম 1, 2, 4, 5, তারপরে গ্যাপ 10, 17। হ্যাঁ, এবার মনে করো আমি 1, 2, 4, 5 পর্যন্ত দেখলাম সেম, 10ও সেম, 17ও সেম। কি করবো? তখন 4, 5, 6 নেব। কেন? যদি if there is one nucleotide mutation, then some part of 5 will go to 6, some part of 6 will go to 7. So if we continue scanning 3 consecutive chromosomes, there's a chance, better chance that we find out the mistake. Right? Because in that case it might have occurred a frame shift mutation. So this will shift from chromosome 6 to chromosome 7 or 7 to 8. Instead of doing 4, 5, 6, we could do 9, 10, 11 also. But 9 and 11, these two chromosome information is less compared to 4 and 5. So we try for 4, 5, 6. If at all we are very unlucky, 4, 5, 6 becomes also same. Then 5, 6, 7. If you are so unlucky, 6, 7, 8. If you are so unlucky, leave it, do some other job. Right? Change the job. Now this kind of pattern is seen, and if any one of you in future go to such field where you perform these tests, you will find percentage matching. In no DNA fingerprinting, they can say alleged father, mother, child. Means this fellow is biological father of the child, cent percent correct, it cannot say. Right? How much similarity we can see? Anything more than 50% is questionable. these two persons might be similar, same. Anything more than 50%. Anything more than 75%, definitely. Why? Because the population number is very high. Within that, 2% from two different parts of the world will come and to give me a false result. Just to just to give me a false result. Just because I am doing the test to make me false, prove wrong, two fellows conspired and came together and gave same kind of DNA result. It is quite unlikely. And again, if you are so unlucky, change the job. Change the job. That's not for you. So here, the lab will say it's around 60%, 70% matching with the alleged father. Okay? Now, other things will be checked. There is a possibility that this fragment 15 is present in the child, not in mother. The child 14, mother 14 is present on child. So 15 present from father, 14 present from mother. The child is formed by adding mother and father's genome. So if the child contains both the fractions from mother and father, that means he is a biological son, a biological child. So there is a possibility that this lady spent sometimes with this man and had this child when her husband was not at home. There is a possibility. Right? Fine. That's all.
Cervical lymph nodes. Now, last day when I was teaching the scalp, now you think of the head and the neck. Now, you just look into the anatomy. Each zone has specific lymphatic drainage. The scalp has, your submandibular region has, the face, the parotid has the specific lymph nodes to be drained into. Now, this just beginning. Now, you see the illustrations here, the preauricular, posterior auricular nodes. See the chain of lymph nodes here. Now, about 15 to 20% of lymph nodes are situated in the region of the head and neck, classified into two groups: peripheral outlying cervical lymph nodes and terminal deep cervical lymph nodes. Most of the lymph from head and neck are filtered through the peripheral lymph nodes. All the lymph from head and neck drain directly or indirectly into the deep cervical nodes. Now, I told you, I think during scalp discussion, that a mother comes with a child and tells you that, see, Dr. Wo, ekhane kichu nodes ache. Nodes bolbe na, je kirom guti daniye jache. Now, you have to DD, differential diagnosis. What can be? Then you ask the mother first thing, that is common condition, pruritus. Infection on the scalp. Then that drains into thing and that. Another thing is very common. Of course, the vaccinations are given and BCG vaccination is given. But yet, tuberculosis is very common in our country. You think of tuberculosis and try to diagnose if it is in that. So, in differential diagnosis, it can be an infective and also tuberculosis for children. even for adults. But any other swelling, just see the swelling, a patient comes with a neck swelling here on the left side of the, just above the supraclavicular region. Then you think of, most of the time, it's the Varshov's gland. That is any malignancy related to the stomach. That might be reflected in this part, Varshov's node. Okay, that you'll be seeing in your the peripheral cervical lymph nodes. The outer circle lymph nodes from the pericervical and cervical collar. See the chain of lymph nodes, and situated at the junction of the head and neck, cranio-cervical junction, and extends from chin to occiput. From the chin to the occiput, in this part. Okay? Peripheral cervical lymph nodes, the inner circle. Lymph nodes surround upper part of the respiratory and alimentary passages. This is the trachea. A chain of lymph nodes going. Lymph nodes surround the upper part of the respiratory and alimentary passages. That means the esophagus, that and the respiratory system, trachea and larynx. Now, if there is a tumor here, the blue tumor of the thyroid, cancer cells in lymph nodes close to the thyroid. The thyroid and the windpipe in trachea, and now situated deep to the investing. Now, lymph nodes surround upper part of the respiratory and alimentary passages, situated deep to investing layer of deep cervical fascia, deep to inner circle, submucosal ring of lymphoid tissue. Waldear's ring surrounds the commencement of respiratory and alimentary passages. Now, Waldear's ring can come as a short note. It's important. The Waldear's ring, just they won't write cervical lymph nodes, but they just give you the name component, Waldear's ring. 4 marks. Then you go and describe the deep to inner circle submucosal ring lymph node, lymphoid tissue is Waldear's ring surrounded by the commencement of the respiratory and alimentary passage. Yeah. Waldear's ring. Now lymph nodes in the outer circle. Submental, 3 to 4 lymph nodes situated below the chin in submental triangle. Yeah. Submandibular, 3 to 4 lymph nodes situated in the submandibular triangle and lie in contact and situated in the submandibular triangle, lie in contact with the submandibular salivary gland. Now, if there is a submandibular gland, usually you cannot palpate, but if there is any swelling of the submandibular gland due to calculus, which is a very common thing, so you ask the patient that when you take some sour, then does it swell up? Because the calculus is in the duct. So you have to lymph nodes in outer circle, parotid, preauricular lymph nodes situated superficial, deep to facial capsule of the parotid gland, lie within the gland. Mastoid, posterior auricular lymph nodes situated superficial to near its insertion. Occipital, situated at the apex of the posterior triangle along the occipital artery. Yeah. Yeah. Lymph nodes in the outer circle, the facial, extension of submandibular lymph nodes, buccal node, lateral surface of the buccinator muscle. When you dissect, you will be seeing in the face and head neck. And if you just squint your mandible, then the masseter becomes, and also the buccinator, lateral surface of the buccinator, mandibular nodes at the crossing of lower border of mandible and the facial vessels. Here the facial vessels in the lower border of the mandible. Here. Infraorbital node just below the orbit. Infraorbital just below the orbit. Lymph nodes in the outer circle, superficial cervical to along the internal jugular vein, extension of parotid node, anterior cervical situated along the midline of the neck along anterior jugular vein. These anterior jugular vein. Extension of the submental nodes. Lymph nodes in the inner circle. Now, infrahyoid nodes lie in front of the thyrohyoid membrane. And this is the hyoid bone. And thyrohyoid membrane, thyroid cartilage to the hyoid bone. Prelaryngeal nodes lie in the front of the cricothyroid membrane. And pretracheal nodes lie in front of the trachea and below isthmus of the gland, thyroid gland here. Lymph nodes in the inner circle, paratracheal nodes flank the trachea and esophagus on either sides. Now, paratracheal nodes, now you see the trachea and the esophagus posteriorly, then it is in between this, in the paratracheal nodes, flank the trachea and the esophagus on either sides. Retropharyngeal nodes lie posterior to the pharynx and in front of the prevertebral fascia. Retropharyngeal, pharynxের পেছনে, retro. Where it then what is the structure? Just behind the pharynx is the vertebral column. So it is in the prevertebral. But তোমরা যেটা করবে এক একটা you draw figures and you mark the position of the nodes. You take a sheet and draw. First of all, মুখস্থ করতে যাবে না প্রথম দিন. You draw a one A4 size paper full big এক একটা component, lateral component, anterior component, like this, posterior component. You just do a sketch and with your color pencils, এরকম যেরকম পজিশন draw sketches and put the lymph nodes in position. Accordingly, you just label the outer circle, inner circle, or paratracheal. Then it becomes easy for you. If you say anterior, now the anterior triangle posterior. Chaitanya, Tiki, and then you just label them and go on marking and labeling, and then it becomes easy for you. When you just with this head and neck of both kotin ache, clavipectoral fascia, all these are very, don't think it in that terms. There are wonderful illustrations in your books. Even I'll tell you, clavipectoral fascia, you download McGregor Surgical Anatomy. If you have the opportunity, you can see it in the, just one read and seeing the illustration. I am saying about all the books, Somar Mitro, everyone, or your Ashim Datta, or Bisram Singh, or your Chaurasia, but the descriptive part is beautifully given in clavipectoral fascia. Is a very common question asked, long question, or at least 10 marks question. And you try to, in this phase of last lap of your syllabus, you try to revise by illustration and points. Then it becomes easy. Now your cervical lymph node, তুমি করতে যাবে থাকবে না, কিন্তু অ্যাটলিস্ট কিছু ছবি ধরো সাবম্যান্ডিবুলার, সাবমেন্টাল, এই জায়গাগুলো জাস্ট একটা ছবি। Now lymph nodes in the inner circle, paratracheal nodes flank. Paratracheal nodes flank the trachea and esophagus on either sides. Retropharyngeal nodes lies posterior to pharynx and in front of the prevertebral fascia. Now, not visible to the last bench, but I'm telling you the way of now revising and studying. With it becomes easy if you go on illustrating. And now deep cervical nodes lie along and around internal jugular vein, situated within carotid sheath and also on the surface, classified as superior group and inferior group, the jugular vein, and with the carotid sheath. So you palpate your carotid artery and see the pulsation, and also you just illustrate that it lies along and around the internal jugular vein. Then the internal jugular vein is there, laterally, even in front. It just forms a network. Now see the internal jugular vein here. The lymph nodes, submental lymph nodes, this mentum is here. Naturally, the lymph node can be palpated here, okay, and submandibular. Here is the submandibular node, and this is the internal jugular vein. See the network. Now, this is the carotid triangle, this is the omohyoid muscle, this is the digastric, and this is the stylohyoid, and this is the submandibular sternocleidomastoid. From the sternum, and the mastoid process of the occipital bone. Now, lie along and round the internal jugular vein, situated within the carotid sheath and also on the surface, classified as superior group and inferior group. Now, superior group situated above the omohyoid muscle, chief lymph node jugulodigastric, situated between the angle of the mandible and the anterior border of the sternocleidomastoid. And drains lymph from palatine tonsil, lymph nodes of the tonsils. Now, a child is having tonsillitis or chronic tonsillitis, acute tonsillitis with a bad sore throat, then at least you go and palpate the lymph nodes and see, because the patient's guardian will ask you, sir, guti daniye gache, what is this, what is this? And you just assure, and then you do an examination of the throat. Ota abar refer to ENT korbe na. It takes just a second. You take a tongue depressor, it's a small blade. কল তোমার পাড়াতে তোমাকে সম্মান করে, তোমাকে ডেকেছে, 4th ইয়ার থেকে তুমি ডাক্তারি করতে পারবে, এই একবার আয় তো, তোর মাসিমণি অসুস্থ বা তোর পিঙ্কি অসুস্থ। এবার কিছুটা আছে দেখতে হবে, তুমি খুব এক্সপার্ট, তুমি শুধু এমনি করে দেখে বলে দেবে যে এটা হয়েছে ওটা হয়েছে। নো, ইউ হ্যাভ টু মানে do jadoo. But I'm using this term, but it is essential to ask. ভয় পেয়ে যাবে, tongue depressor তো 90% people don't carry, doctors. So you take a চামচ দাও তো একটা, then you ask for a spoon and tell the patient to open the mouth and you depress the tongue and see the condition with the torch. But if you are past MBBS, you are practicing in the locality or any other place, you make a small box, you have a BP instrument, you have a hammer and also a tongue depressor, also LED lights, beautiful LED lights, chotto chotto, darun alo. You of course, if you find a bad pathology, because I tend to say the severe tonsillitis, now you have to give antibiotics, you have to give analgesics and antipyretics. Now this thing will you diagnose and you see the palpation of the lymph nodes from this thing you see and drain the lymph node from the palatine tonsils to the lymph node of the. Now, inferior group situated below the omohyoid muscle, chief lymph node, jugulo-omohyoid node, situated posterior to the internal jugular vein and deep to sternocleidomastoid, drains lymph primarily from the tongue, lymph node of the tongue. Now, this is important because now the era of Gutka, 5000, Bimal, and our icons, Shah Rukh Khan, Ajay Devgan, and some other persons is included. কি একটা টিভিতে দেখাচ্ছে না এরকম কেশরী, হ্যাঁ, তো everyone is getting some substance abuse. আর শাহরুখ খান খাচ্ছে, তাহলে আমি একটু পুড়িয়া খাই, রাত্রে 11টার সময় ঘুম পাচ্ছে, অ্যানাটমিতে ধুলছো, তখন একটু পুড়িয়া খায়। No, no, no. But when you are in your clinic, একটা জেনারেল এক্সামিনেশনের মধ্যে তুমি কুইক within 5 minutes you gather information and open your tongue. If you feel that something is wrong with the tongue, or it might be submucosal fibrosis of the buccal mucosa, it हाँ करते आते हैं এরকম করে চলছে, হ্যাঁ, আবার পুড়িয়া খাচ্ছে। Now this you take your finger, কিচ্ছু নয়, you don't have a gloves, then you wash your hands and put your finger, index finger, and see and feel the tongue, see if any ulcer is there or any growth. These things, it might be inflammatory, it can be malignant. So these things are inflamed. Naturally, their lymphatics are draining into the cervical groups. একদম মানে তাড়া আছে, নো তাড়া, তোমার 5 মিনিট 10 মিনিট তুমি 1000 টাকা নেবে না 500 টাকা নেবে, that is your discretion, but examine the patient quick. However busy you are, সব সময় ইএনটি, আমি যদি কোনো ইএনটি ডাক্তারকে পাঠাই তাহলে আমাকে পাঠাতে হবে মেডিকেল কলেজে, শান্তিনিকেতন, or some other person, but many persons I don't know the name, or anything I find grievous, if I feel that he needs some surgery, I send it to Professor Manoj Mukherjee in Burdwan. He's from our institution, but he's a brilliant surgeon, brilliant ENT doctor, and actually I myself have otosclerosis. Naturally ENT কম্পোনেন্টটা আমার খুব মানে আমার সবই ভালো লাগে, কিন্তু আমি এটাকে খুব নজর দিই। হ্যাঁ করো তো, হ্যাঁ দেখলো, জিভ দেখাও, any gastric problem or something like that, then you have to look into it. Now inferior group, the inferior lymph nodes situated in the supraclavicular fossa, Virchow's lymph node, যেটা আমি বলেছিলাম, Virchow's lymph node and common site of metastasis from malignant carcinoma of the stomach. তোমাকে প্রথমেই তো জিআই, তোমাকে এখানে একজন এলো বললো বমি করছি, আই এম ভমিটিং, হ্যাঁ, বমিটা কিরকম হয়, ভমিটাসটা কিরকম, কফি গ্রাউন্ড, মানে অ্যাকচুয়ালি ব্লাড গোজ ইনটু দি স্টমাক and with the acid it turns into coffee ground color, and these are the indications for gastritis, gastric hemorrhages, duodenal ulcers or gastric ulcers, or your stomach carcinoma. Now testicular and esophageal cancers can also metastasize in these nodes. Then lymph nodes situated in the supraclavicular fossa, Virchow's lymph nodes, common site of metastasis for malignant carcinoma of the stomach. Testicular and esophageal cancers can also metastasize in these nodes. Now, তোমাকে দেখাতে হলো পেট, তুমি তাকে বললে প্যান্টটা খুলুন, no, but you can ask যে do you have any এখানে কোনো হাইড্রোসিল আছে বা কিছু আছে, যেটা কমন ল্যাঙ্গুয়েজ ইউ ইউজ। নাও ইফ ইউ টেল হিম, তাহলে আমাকে দেখতে হবে আমাকে, ইউ সি ইফ দি টেস্টিস ইজ হার্ড or soft or it is not hydrocele contains fluid, but the component of the testis, it can be seminoma, teratoma of the testis. So testicular tumors, they metastasize to the Virchow's lymph nodes, supraclavicular lymph nodes, and Now, surgical classification of cervical nodes. Level 1 submental group, level 2 submandibular group, level 3 jugulo-digastric group, level 4 jugulo-omohyoid group, level 5 posterior triangular with supraclavicular group, level 6 anterior midline group. Now, this diagram, you have to know surgical classification of the lymph nodes. Now, the surgical classification of the lymph nodes gives the level 1 is submental group, level 2 submandibular group, level 3 jugulo-digastric group, level 4 jugulo-omohyoid group, level 4 posterior triangular with supraclavicular group, and anterior midline group. This. তার মানে এখানে তোমার ইলাস্ট্রেশনটা খুব ইম্পর্টেন্ট। You can say, they can ask you 10 marks question that surgical classification of cervical lymph nodes. So please make it a point and note this. Now, clinical anatomy. Now, classical radical dissection, removal of level 1 to 5 nodes, removal of sternocleidomastoid, internal jugular vein and spinal accessory nerve, modified radical neck dissection, removal of level 1 to 5 nodes and sparing other structures, selective neck dissection, removal of some, not all, of level 1 node, 1 to 5 nodes, radical neck dissection plus dissection of the involved area, commando operation. Now, this is the region where head and neck surgeons and mostly ENT surgeons are operating in this level. Thank you. Then please, you try to learn, read your books, whichever you feel the book is given there, but for your practice, you just draw illustration for every chapter what you are studying. রাত্রে ঘুম আসবে, ছবি আঁকতে থাকবে, তো হাত ধোলা অবস্থায় 25% ঢুকবে মাথায়। Wish you all the best. And next, I'm having your pelvic organs for demonstration. Please come over.
Write it down. How will you determine the site of adductor tubercle? No. Okay. So first, thigh is abducted and laterally rotated. Write it down. Thigh is abducted and laterally rotated with knee and hip slightly flexed. With knee and hip slightly flexed. You have written. And the tendon of adductor magnus is to be followed downward. Tendon of adductor magnus is to be followed downward to feel the tubercle a little above the medial condyle of the femur. To feel the tubercle a little above the medial condyle of the femur. এই পিছনে তোদের অ্যাপ্রন কোথায়? অনেকজন অ্যাপ্রন পরে আসিস নি। ডিসেকশন ক্লাসে অ্যাপ্রন পরে আসতে হয় কিনা? হয়েছে এই অবধি লেখা অ্যাডাক্টর টিউবারকেল। Oh. Thigh is abducted and laterally rotated with knee and hip is slightly flexed. Tendon of adductor magnus is to be followed downward to feel the tubercle a little above the medial condyle of the femur. Okay, হয়েছে লেখা? তাড়াতাড়ি লেখ, এত স্লো লিখলে কি করে হবে? পরীক্ষায় কি করে কমপ্লিট করবি? হয়েছে এটা? ওকে, নেক্সট পয়েন্ট লেখ। টিপ অফ দ্য মিডিয়াল ম্যালিওলাস। Tip of the medial malleolus, লিখেছিস? Okay, so it is the lowermost point of the medial malleolus. Write it down. It is the lowermost point of the medial malleolus. হয়েছে লেখা? Okay, next we go to tip of the lateral malleolus. লিখেছিস? It is the lowermost point of the lateral malleolus. হয়েছে এই অবধি। নেক্সট গো টু tuberosity of the navicular. Tuberosity of the navicular. লিখেছিস tuberosity of navicular? A point, write it down. A point 2.5 centimeter below and in front of the medial malleolus. A point 2.5 centimeter below and in front of the medial malleolus. You have written? Yes or no? Okay, next is sustentaculum tali. Sustentaculum tali. A point 2.5 centimeter below the medial malleolus. লিখেছিস তাহলে a point 2.5 centimeter below the medial malleolus. Okay, next write down anterior superior iliac spine. Anterior superior iliac spine. It forms a palpable, occasionally visible, elevation at the lateral end of the fold of groin. At the lateral end of the fold of groin. Written up to date? Okay, next write down tubercle of iliac crest. tubercle of iliac crest. It lies about 5 centimeter behind, write it down. It lies about 5 centimeter behind and above the anterior superior iliac spine. It lies about 5 centimeter behind and above the anterior superior iliac spine. And the plane passing through the two tubercles is known as transtubercular plane. Okay. So, another point you write down, transtubercular plane joining the, you write down from here, transtubercular plane joining the tubercles of both iliac crests passes through the upper border of fifth lumbar spine. Passes through the upper border of fifth lumbar spine. Okay, understood? That's how you identify the fifth lumbar spine. Okay. Next, we go to tibial tubercle. Tibial tubercle. Or tibial tuberosity, you have learned during the bone tibia. Tibial tubercle, write it down. It is a subcutaneous projection. It is a subcutaneous projection of the upper end of tibia. Where the ligamentum patelli is attached in its upper part. Where the ligamentum patelli is attached in its upper part, and the subcutaneous anterior border of tibia extends below. Subcutaneous anterior border of tibia extends below. Written up till this. Okay, next go to head of fibula. Head of fibula. It is a slight elevation. Slight elevation on the posterolateral aspect of the upper part of leg. It is a slight elevation of the posterolateral aspect of the upper part of leg. And lies vertically below the posterior part of the lateral condyle of the femur. and lies vertically below the posterior part of the lateral condyle of the femur. Okay, you have written? Okay. Next we go to the lines. Write down lines. All these are points. Okay. You have to draw one point and one line, and that will be from different region. Okay. Point coming from supex, then line can come from the head neck like this. Next go to the line. First is popliteal artery. Write it down. Popliteal artery, a point 2.5 centimeter medial to the, write it down, 3 points you have to take, then you have to join the 3 points. Okay. So first point we are discussing. You write down A, B and C. So first A point 2.5 centimeter medial to the midpoint of the transverse line on the back of the thigh at the junction of upper 2/3 and lower 1/3. Okay, written. Next go to B, point B. Point B is a point at the middle of the back of the knee. A point at the middle of the back of the knee. Then C, point C, midpoint of the transverse line. Point C, midpoint of the transverse line on the back of the leg at the level of neck of fibula. Written 3 points. Yes or no? Now, these 3 points are joined by a double line. These 3 points are joined by a double line. Passing downward and laterally. Passing downward and laterally with pink colored chalk dust. Why pink colored? Because it is an artery. Okay, you will be asked questions regarding this. It is an artery, that's why we are drawing a double line, because artery has a lumen, and pink color because artery is color code is red. Okay, so red chalk dust not available, pink available, so you draw with pink color. Okay, you have written, all of you. Next, posterior tibial artery. First point, here 2 points you have to take, point A and B. First point, a point at the end of the popliteal artery. Previous one we have drawn popliteal artery, last point is the end of the popliteal artery. So that will be first point for this posterior tibial. Popliteal artery divides into anterior and posterior tibial artery. So the end point will be the beginning of this both artery, anterior and posterior tibial. So first point is a point at the end of the popliteal artery. Next point is midpoint between the medial malleolus and the tendocalcaneus. Midpoint between the medial malleolus and tendocalcaneus. Tendocalcaneus. Okay, so you have written. Okay, now these 2 points are joined by double line with pink chalk dust. Okay. These 2 points are joined by double line with pink chalk dust. This is also a artery, posterior tibial artery. That's why double line and pink color. Okay. And during surface marking, you always take consent from the person over which you are drawing. Okay. That also carries mark. And before leaving the place, you remove all the chalk dust with cotton or something. Okay. These parts are also carrying marks during surface marking. Here today we will draw over the cadaver, but during exam one of the attendant will volunteer and over which you have to draw all the points and lines. Okay, understood? Okay, next we go to tibial nerve. Tibial nerve. Here you have to take 3 points A, B and C. Okay. First point is midpoint of the line. Write it down. First point is midpoint of the line on the back of the thigh at the junction of upper 2/3 and lower 1/3. At this level, the sciatic nerve is dividing at the upper angle of the popliteal fossa. You have seen during dissection, upper angle of the popliteal fossa, sciatic nerve is dividing into 2 nerves, tibial nerve and common peroneal nerve. Okay. So this is the point. First point you have written, all of you. Okay, next point. Midpoint of the line on the back at the level of the tibial tuberosity. Written midpoint of the line on the back at the level of tibial tuberosity. You have written. Next, third point. Point C, point of end of the posterior tibial artery. That is midpoint between the medial malleolus and tendocalcaneus. Okay. Previous one was posterior tibial artery. So the second point of posterior tibial, same point. Okay. C, point of end of posterior tibial artery. Okay, understood? During Viva, you have to tell the midpoint between the medial malleolus and the tendocalcaneus. Okay. And as it is a nerve, you have to use yellow chalk dust. Okay, color code for nerve is yellow. Now write down, join these points with a single line with yellow chalk dust. Join this point with a single by a single line with yellow chalk dust. Single line because nerve is a solid structure. It does not have any lumen. Okay. You have known all these points during superior extremity surface marking. All these have been discussed. Okay. So join with yellow chalk dust by a single line. Next we go to common peroneal nerve. Don't talk. Common peroneal nerve. কি কথা বলছিস তোরা ওখানে তখন থেকে? তোরা তিনজন, হ্যাঁ, কি ডিসকাস করছিস? Okay. For this you have to take 2 points. Okay, first point is beginning of the tibial nerve. Next point is a point at the lateral side of the neck of fibula. A point at the lateral side of the neck of the fibula. These points are joined by a single line along the medial border of biceps femoris muscle. Along the medial border of biceps femoris muscle. With yellow chalk dust. This is also a nerve with yellow chalk dust. Okay. Understood? Okay. So all these lines are located on the posterior aspect. Okay. Next we go to the anterior aspect lines. On the anterior aspect, first is anterior tibial artery. Write it down, anterior tibial artery, and you also note whether it is right side or left side, and you have to draw on the same side which have been mentioned in the card. Okay, if it is mentioned right side, you have to draw on the right side of the patient. Okay, understood? That also you have to be correct about this. Okay, so first is anterior tibial artery. 2 points to take. First point is a point 2.5 centimeter below the, write it down, 2.5 centimeter below the medial side of the head of the fibula. So first point is a point 2.5 centimeter below the medial side of the head of the fibula. Okay. Next point is midpoint between the two malleoli. midpoint between the two malleoli, lateral and medial malleoli. Okay. And the point must be lateral to the tendon of extensor hallucis longus. And the point must be lateral to the tendon of extensor hallucis longus. Okay, written everyone? Okay, next line is dorsalis pedis artery. Write it down, dorsalis pedis artery. Okay, anterior tibial artery is continuous beyond the ankle of the dorsalis pedis. Okay, so its beginning is the end of the anterior tibial. So first point is midpoint between the two malleoli. Write it down. And second point is a point at the base of the first intermetatarsal space. Second point is a point at the base of the first intermetatarsal space. Okay, and these two points are joined by two lines with pink chalk dust as usual, joined by double line. Okay, joined by double line with pink chalk dust. Next is one nerve, deep peroneal nerve or anterior tibial nerve. Deep peroneal nerve or anterior tibial nerve. 2 points you have to take. First point, a point on the lateral surface of the neck of the right fibula. A point on the lateral surface of the neck of the right fibula. Then second point is midpoint between two malleoli. This is the site of neurovascular bundle, and neurovascular bundle was containing anterior tibial artery with many committantes and this deep peroneal nerve. Okay, and this deep peroneal nerve, it is one division of common peroneal nerve. Common peroneal nerve was ending near the neck of the fibula, and here it is dividing into two nerves, deep peroneal nerve or anterior tibial nerve, another one superficial peroneal nerve. Superficial peroneal nerve was nerve of the lateral compartment, and this deep peroneal nerve is nerve of the anterior compartment of the leg. Okay, understood? And posterior compartment nerve is the tibial nerve. You have seen during the dissections. Okay, and join these 2 points by a single line with yellow chalk dust. Understood? Up till this you have written. Next is one artery, femoral artery. Write it down. Femoral artery. you have to take 2 points. Okay, first point is mid-inguinal point. Mid-inguinal point. What is mid-inguinal point? Give a hyphen, a point midway between the anterior superior iliac spine and the symphysis pubis. This is very frequently asked in your viva. What is mid-inguinal point? Okay. First point is mid-inguinal point. Write it down. A point midway between the anterior superior iliac spine and the symphysis pubis. Next point, write down another point in the adductor tubercle. Adductor tubercle we have discussed during the points. Okay, another point you have to take at the adductor tubercle and join these 2 points by a line. Write it down. Join these 2 points by double line, actually double line. Upper 2/3 of the line represents the femoral artery. Okay, upper 2/3 of the line represents the femoral artery, and you have to draw these points and lines when the thigh is flexed, slightly abducted and laterally rotated. Write it down. Draw all these points and lines when the thigh is flexed, slightly abducted and laterally rotated.